opportunity. So I'll be presenting on spine surgery, a guide to a seamless learning path. I have no financial disclosures. So as we all know, there's a learning curve in spine because of all these possible reasons like suction loss. As Dr. Solgoil rightly mentioned, it has decreased in Wismax 800. So then you have black spots, which Dr. Sahil also showed, and it's all because of the debris, moving secretions, excessive drying, or if you're using low energies. And then opaque bubble layer, if you are using high energies, then you have cap lenticular adhesions, retained lenticle tear, cap tears, false plane creations, and of course there are challenges with enhancements. So I'm just going to go through the procedure. It has been told before by numerous speakers, so I'll be very quick in this. So you apply the suction. The application after 80%, you apply the suction. This is the lenticule cut, followed by the lenticle side cut, and then cap cut, followed by the cap cut, side cut. So nowadays I'm using a 2 mm side cut. So you go with the Sinsky hook, open the interior cap first, followed by the posterior cap, and then I use Reinstein dissector. So I just, if you see here, I go in slowly, and with one sweep, I just complete my interior plane dissection. And then going ahead with the posterior plane. So usually what I do is I separate the plane, the posterior dissection till the lenticle side cut to avoid any fold, and then I go ahead with the posterior dissection, leaving 2 anchor points at 3 and 9 o'clock, and then I'm going to remove the lenticule with the same dissector. So you just have to fold it, and with the same dissector, the lenticule is out. So just a small pearl here is like, as you must have seen, I took my lenticule dissector only thrice in the central part of the cornea. So what happens is, if you move it a lot of times in the central part of the cornea, there's friction, there's corneal edema, and there's less chances of wow factor the very next stage. So this is just a small pearl. So it's just the first 50 cases, 50 eyes that you have to go through. Once you go through that stage, all challenges in smile can be manageable. So coming to suction loss management, the predisposing factors, it is due to surgeon's inexperience, mechanical factors like tight speculum, improper drape surface to it, anatomical factors like deep socket, narrow palpebral apertures, uncooperative patient, and anxious patient. So I'm just going to show a few of my initial cases. So this is the suction loss management which is provided by the Zeiss machine. So the only stage where you can have a problem is when you have a suction loss at lenticle stage of more than 10%, where the machine tells you to convert it into a femtosecond LASIK or a PR case. So I'm going to tell you a way out in that in my subsequent slides. So coming to the first case, suction loss at the cap side cut. So patient, as Dr. Sheetal in the morning showed, you encounter such patients who are very uncooperative, anxious, and have loose conjunctiva, as they're all contact lens users. So this was a patient who was uncooperative, had loose conjunctiva, his refractive power in the right eye was 0.5 with 2.25, 180, left eye 0.75 with 1.580. I usually take an optical zone of 6.5 in all my cases. So I started the case. He was anxious, uncooperative. So you can see the loose conjunctiva coming in through the superior side. Usually it comes through the superior side because of the Bell's phenomena also. And you can see the cap side cut happened on the conjunctiva. So there was a suction loss. You can see the stage. It happened on the cap side cut stage. So as the complete protocol says, you have to repeat it from the cap side cut by decreasing the diameter by 0.2 mm. So I did the same thing. I continued, but you can just see that what has happened here is the cap side cut is overriding the lenticle side cut, and plus as it happened on the conjunctiva, so you have to know that your cap cut is superficial on that stage. So I did the cap side cut only. I could have some distance between the lenticle side cut and the cap side cut. So I started from the other side, did the interior dissection first, followed by the posterior plane dissection. So I continued the interior plane dissection, in a routine way, and suddenly I realized there was a cap there because of the superficial cap cut in the superior area because of the conjunctiva coming in the femtosecond laser application area. So as I knew, so I was little careful. I knew there was a cap there, so I was more careful in that area to avoid any more further increase in the cap there. And you can see I separated it carefully, and the lenticule was up. So coming to the left, I am the same patient as I already knew that he was anxious and he had loose conjunctiva. So I did a small trick. What I did here was I changed my cap side position to 150 degree because usually the conjunctiva comes in through the superior position because of the Bell's phenomenon. So what I did, I continued the same thing. The only difference was I created a cap side cut little temporarily, and you can see that he again started moving, and the conjunctiva again came in, but luckily it was on the temporal side. So there was, I didn't have any problem. So this is just one small goal that you can do when you realize that the patient is having a loose conjunctiva, and everything went uneventful, and the post-operative vision was also 20/20. So cap tears are basically astigmatically neutral. So you use ECM in large cap tears. You can do an intentional suction loss also, because if you do it during the cap stage, that's the most easy thing to do. You can just repeat the cap from the cap stage. Use infrared light to re-lock, or you can wait it in the, like you can do other patients, do it in the end so that the ovules disappear. Or you can make a cap side cut nasal or temporal as I did it in the other eye. So this was another case where the suction loss happened at the lenticle cut stage. So patient again was uncooperative, was little apprehensive, anxious. So you can see that he moved. So I continued, but while I was going to complete, it was a suction loss. So usually nowadays what I'm doing is in all my moderate myopia where I have good thickness, I'm using 130 cap. So this gives me another chance to do a re-smile in the same sitting. So I changed my cap parameters to 100, reduced my optical zone from 6.5 to 6, and I could continue in the same sitting, because you know when your first eye is done with the smile and then you have such a loss in the other eye, and it becomes really difficult to explain it to the patient that you have to convert it into a femtosecond LASIK flap. So you can avoid that by regularly using a good cap thickness of 130, and then you can just decrease your cap parameters to 100 and do a re-smile in the same setting. So that's what I did, and the vision was 20/20, everything was perfect, so it went uneventful. So, but if you are using a thin cap, especially when you use it in high myopes, so then at that point you have to convert it into a femtosecond LASIK if you encounter such a problem. So another case is suction loss at cap side cut stage. So what happened was I continued. It was a routine case, but the lenticle side cut happened. The cap cut also happened in a good way. So you can see that the conjunctiva coming in, and what happened was the cap side cut. It didn't happen. It happened on the conjunctiva. So I tried finding the incision. I couldn't find it. You could have done manually, but the thing is, when you do it manually, what happens is you can enter into a wrong plane and it can lead to a false plane. It can have further problems. So what would you do in this case is, like how your assistants do calibration of the machine. What you do is, Dr. Sonubal would definitely agree. He also had done this. So you use your fingertip, apply a suction on the fingertip, do an intentional suction loss at cap side cut, so that you can get, you just have to use a new code. You use it from the cap side cut stage and apply it on the cornea, and you can just do cap side cut only. So you can do that also. So this using another code for cap side cut, you can also do it when you have a false plane creation. We haven't had this, but we have seen these cases, especially when you are an initial beginner. What happens is you don't know the right plane, so you make false passages. So what you do, just forget about that incision, make another incision, on the temporal side at least 30 degrees apart and just start all over again so that it becomes an uneventful surgery. Another case, it was a misaligned lenticular side cut. What happened was I was continuing lenticular cut. All these problems have been decreased significantly, as Dr. Sonu mentioned about the new Wismax 800. But what happened was, you can see that there was a misalignment of lenticular side cut on the right side. So I went ahead with the case. I started my case, did an anterior dissection. So as I knew there was a misalignment of the lenticular side cut, so I knew that there was no side cut on the right side of the lenticle. So anterior cap dissection was done normally. There was no difficulty in that. But while I was doing a posterior plane dissection, so I was able to separate the lenticle on the left side, but on the right side I was not able to do it because there was no lenticle side cut on that part. So I was trying to do it, I was not able to, so I was just scared, like I could have had a remnant of a lenticle, or I could have a lenticle tear in it. So being a cataract surgeon, you can use these forceps, hold the flap as close as possible to the root of the tear, do a rexis kind of motion, stepwise guided circular fashion, and you can see that I was holding it as close as possible to the tear in a stepwise guided way. I was able to take out the lenticle, which was very easy in the end, and there was no lenticle remnant also in it. You can check the remnant lenticle with the triamcinolone acetate also. So that's another thing. So vision was perfect. So coming to the last stage, we always encounter an unintentional posterior plane dissection. Even after doing so many surgeries, you have this once in a while. So this is just a case where I was doing it, and I started the plane dissections, and when I inserted the Einstein dissector, I suddenly realized that there was a slight more of resistance which I could feel. And when I went to the periphery, I could see that there was a separation of lenticle. So what you have to do is just scratch it on the edge of the lenticle, try to find out the plane, anterior plane, and then just go ahead and do a good anterior plane dissection. So coming to the take-home points, suction loss, of course, has less chances in Wismax 800. If you have a retained lenticle, use triamcinolone acetate to stain it. Cap tears, it is common in thin cap smile. So always visualize the tip and elbow of the instrument while you are doing the dissection. And even if you have a cap tear, don't worry, it is astigmatically neutral. If you have a false plane creation, you can create a new cap side cut, as I told you before. Try to keep a smile cap of 130 microns, as it gives you an additional advantage of less dry eye. You can do a re-smile and retreatments. And retreatment, as it is shown by Dr. Amit, he showed that it is very less with smile. So my preferable choice is femtosecond LASIK, and you can do circle for thin cap smile. Thank you.
Thank you. I think we also need to know what can go wrong, and you beautifully managed some of the cases. I remember once discussing with Dr. Amit also, like I think you felt there was a side cut, the side cut was not created, and you I think went in manually, I think once, and very beautifully.
Feel the circles of way. So again, we use the circles of way. So we just had the cut of course, like maybe 30 degrees or something. So instead of creating a flap,